Welcome to Neonatal Impedia, your trusted source for neonatal parent and provider information.
Hey guys, welcome to Neonatal Impedia. Today I'm going to discuss with you differential diagnoses in the NICU. This is for our novice nurse practitioners, people who are just starting NNP school and an NNP program. I have had some students recently who've had just a difficult time understanding exactly what a differential diagnosis is, how you decide what is on your differential versus what your final diagnosis is. So that's what we're going to talk about today. So what is a differential diagnosis? A differential diagnosis is a group of diagnoses that help you decide what the patient's actual final diagnosis is. So, for example, if you have a baby who delivers at term and has respiratory distress at birth, requiring oxygen, requiring any sort of ventilatory support, you need to decide and you need to list the different problems that it could be, and then slowly narrow your way down on what the actual diagnosis would be. So I'm going to show you a chart, and this chart is going to help us explain the different steps of differential diagnoses. Okay, so this chart shows the 5 steps that can help you with your differential diagnoses. The first step is data collection. This is where you go to your chart. In particular, in the NICU, your mom's chart. And this is if the baby is new. If the baby is, a couple months old, you might not need to know the maternal history as much. And so you would need to go to your patient's chart. So when you go to the maternal chart, what things you need to look for? You need to understand what type of delivery was it? Was it vaginal? Was it a C-section? Mother's prenatal labs. Were they all negative? Is there anything, do you need to look at mom's blood status? Could there be a Coombs positive baby? You need to look at any infectious disease labs to see if any of those are positive or negative. And particularly, you need to look at the GBS status of the mother. You need to look to see if mother had good prenatal care. Did mom go to her doctor's appointments when she needed to? Or was she a more late onset prenatal care where we don't have as good of a picture about the mom's history, medical history? Another thing you need to look at, does the mom have any health problems that could affect the baby that we need to be concerned about? So after you go through your the maternal medical records and know everything you need to know about the mother's medical history along with the delivery history and anything, the history that happened during pregnancy, you need to then do a physical exam of your baby. Do a complete physical exam. This includes collecting vital signs, includes the patient's overall appearance. This is something we do on every baby every day, and you need to note if there's any changes from a normal newborn exam. This is where your physical assessment skills are very important. So after you look at your data collection, then you look at your physical exam. I'm going to go back to the term baby that has respiratory distress, comes over to the NICU requiring oxygen. So then you're going to come up with a primary list of differential diagnoses for this baby. So if you know we have a baby who is term, who was a C-section, and the baby was having some grunting and retractions following delivery, required CPAP via bag and mask in the delivery room, and is requiring about 30% oxygen. What are some of the differential diagnoses that you could have? Any questions? Any answers? If so, leave them in the comment box. But what I'm going to tell you now is, so on my differential for this baby, I would want more information, of course. I gave you a very brief history of the child, but my top diagnoses for this baby would be respiratory distress syndrome of the newborn, TTN, which is transient tachypnea of the newborn, and then my other one would be observation for sepsis. So we would need to rule out sepsis in this baby. So because those are my 3 top diagnoses on my differential, we need to start trying to narrow this down. So to do this, we need to look back at our data, look at our physical exam, how the baby looks, and start narrowing things down. Then you need to come up with your primary list of differential diagnoses. And then after that, you need to go to your diagnostic testing. So what are some things that we would want to do to be able to narrow down this differential? Well, we're going to want to check for infection. So we'll get a CBC blood culture. Depending on the baby's status, you might or might not go ahead and start antibiotics. More than likely on this baby not, but it's something that you definitely need to consider, depending on how the baby looks and their overall condition. Then you need to obtain a chest x-ray and blood gas. So based on these things, you're going to be able to narrow down, what is going on with the baby and what your final diagnosis is. So after this, you're going to look at the chest x-ray. So say you have a chest x-ray that is streaky with fluid in the fissures. Your blood gas is normal. And then your CBC comes back. It has one band, so it's not shifted. White count's normal, platelet count's normal, and your blood culture, of course, is pending at this point. Based on those different things, I would be able to narrow down that this baby has transient tachypnea of the newborn and begin treating the baby as if it has TTN. We would still have sepsis, possible sepsis, on our diagnosis list. And why is this? It's because we cannot exclusively rule out sepsis until the blood culture comes back as final. Usually after the first 48 hours, that is when we would say, okay, this baby more than likely doesn't have an infection. But to truly rule it out, we would need a negative blood culture at 5 days. So now knowing this information, we can make our final diagnosis and we can start treating the baby. So what we're going to do for TTN, we're going to do supportive care. We're going to give them oxygen by whatever means we need to, whether it be CPAP or high-flow nasal cannula. We're going to support their saturations. We are going to support their fluid and electrolyte balances, so we make sure they stay nourished. And we let them work it out on their own. We could also talk about other differential diagnoses. So let's discuss a baby who was born at 28 weeks, is now 4 weeks old, so we're corrected to 32 weeks. So that means we're about right at a month old, 4 weeks old. The baby has been tolerating full feedings of mother's breast milk with Prolacta plus 6 and has had a poochy belly for pretty much their whole life. The baby respiratory-wise is on CPAP of plus 5. FiO2 has been 21 to 30%. She does have some events, but they're very brief and self-resolving. We've already discussed her nutritional status. And at this point in her life, she has no IV access. She is on no antibiotics, and she's been kind of feeding and growing, cruising along. So let's say that this baby now, you get called to the bedside, and the baby's belly is very distended and tense. There's a little bit of discoloration. It is definitely a change from her normal poochy belly that you see. So when this happens, what are you going to do? How do you start your differential? How do you know what's going on with this baby? So in this situation, we're going to do our data collection, which I've already basically told you. We're a 4-week-old baby who is corrected to 32 weeks. We're 4 weeks old. We've previously been tolerating feeds, and we're on CPAP. So there's your background information. You also at this point would be able to say, do I have a previous CBC that I can look at the crit to make sure that the last crit was fine? We're not anemic. Then you're going to do a physical exam, which we've already done. So our belly is distended, it's tense, and has a little bit discoloration around the umbilicus. Overall, the baby's active, has good color, but still just doesn't look quite right. The belly looks a little different than it had been. So at this point, okay, let's come up with what could be going on. This could be CPAP belly, which she's had. It could be, so we could say we have abdominal distension related to CPAP. We could have necrotizing enterocolitis. We could have observation of sepsis. So we could have a UTI. We could have a bloodstream infection. Or we could just have feeding intolerance caused by the Prolacta or possible by the maternal diet. So here's our primary differential list. And then after this, we need to go to diagnostic testing. So at this point, what would we do for this baby? We want to get a KUB to look at the belly on x-ray. You are going to want to get a CBC and blood culture. And since this baby's 4 weeks old, you would also want to get a urine culture. More than likely at this point, you would want, but so I'm getting ahead of myself because that's what we do, right? So there's our diagnostic testing. These are some of the things that we're going to look at to try to make the final diagnosis so we can begin treatment for this baby. If you can think of any other testing that we would need to do on this kid, just let me know, because I can always forget things, right? So then at this point, we're going to look at our diagnostic testing. We're going to look at our CBC. We're going to see what it looks like. We're going to, be following our urine culture, following our blood culture. And, say the CBC is shifted. You have 30% bands. Platelet count's fine. We're not anemic. Our crit's 45. White count's okay. So you say, ooh, something's going on. She's got a lot of immature cells. So, there is a possibility of sepsis. So you keep that on your differential, right? You get the KUB. The KUB doesn't show any pneumatosis, no free air, just shows very dilated loops, but there's also some thickening of the bowel wall. So you go, ooh, okay, probably don't need to feed this belly. So let's make her NPO, start some maintenance IV fluids, and then put a Replogal or an Anderson in. So that's going to be a tube that goes in their mouth, and we can do a low intermittent suction, which is at about usually 60 to 80, 60 to 100 on our suction, that goes intermittently to try to decompress the belly. So at this point, you've ruled out CPAP belly, right? Because there is a change in the physical exam, and you also have seen a change in the amount of dilated loops on her x-ray, and she has a bandemia now on her CBC. So we can rule out CPAP belly. We need to continue the infection diagnosis because there again, we have a shifted CBC, but we have a pending blood culture and urine culture. We really need to keep a risk for neck. We don't have pneumatosis yet, but because of the thickened bowel walls, that can be concerning that she is possibly could develop neck, especially with the feeding intolerance and the abdominal distension. We also look at our data collection and note that she's 4 weeks old and she's 32 weeks. Prime time for babies to get necrotizing enterocolitis after birth. This is, when a lot of babies actually do get neck, and they're considered in their neck window. So we've already made our final diagnosis. This is like an ongoing list, right? Because we don't know exactly what's going on with her yet, but we've taken CPAP belly off. We're saying now that neck and infection are the two possible risks. So we're going to treat for those things. So we're going to continue NPO. We're going to continue the Replogal to decompress our belly. We're going to follow those cultures and start antibiotics. And we're going to continue those antibiotics for at least 48 hours until some of the cultures come back to negative. I hope this helped you guys. Thank you for listening to Neonatal Inpedia, and I hope you enjoyed it. If I missed anything on our differential diagnoses talk, please let me know. I would love to discuss it with you. And if you enjoyed this, just subscribe. Have a great day.
Here at Neonatal Inpedia, our mission is to provide invaluable guidance and support to both parents with NICU babies and the incredible NICU staff who support them. We understand the challenges and emotions you face every day, and we're dedicated to be your go-to resource. However, it's crucial to emphasize that the information we provide is not medical advice. While we strive to offer accurate and evidence-based insights, every baby and every situation is unique. Therefore, we strongly encourage you to consult with your healthcare provider for personalized guidance and recommendations tailored to your specific circumstance. As we wrap up this video, we want to remind you that you are not alone in this journey. We are here to empower you with knowledge, offer comfort, and foster a sense of community. Together, we can navigate the complexities of neonatal care, and together we can provide the best possible care for these precious little ones. Please remember to like, subscribe, and hit that notification bell so you won't miss any of our future content. Your engagement fuels our commitment to create more videos that matter. Thank you again for joining us on Neonatal Inpedia, and we look forward to being a part of your ongoing journey. Until next time, take care, stay strong, and know that you are making a world of difference in the life of your NICU baby.